just touch on what we were talking about? In the event that all of the lorazepam were by IV or injection, how much would you expect there to be in the stomach?
I would not expect to find any lorazepam in the stomach. Free lorazepam.
Well, the fact that there's any free lorazepam in the stomach, what's that tell you?
That tells me that Mr. Jackson had taken oral lorazepam at some time prior to his demise. And I would add that the simulations that I asked Dr. Ornelas to perform did take into account the time that would have been required for the pills to be absorbed and achieve peak effects and to achieve the desired target concentration at the time of death.
Right.
Yes. Okay.
Quadruple pop.
All right.
Now, I want to discuss this document. I believe it's prepared by Dr. Schaefer. These are rejected scenarios. You recognize that document?
Yes, I do.
I want to refer you to scenario number 2. Propofol, 50 milligrams, and I want to put Dr. Schaefer's depiction that he explained and based upon your study by Kim, Kill, and White. I think it's previously been marked as Triple H. That scenario, what does that assume?
Well, it assumes that a bolus injection of 50 milligrams of propofol was injected over a period of, it looks like probably 30 to 60 seconds, very sort of a rapid bolus injection. And one would assume, again, I'm just speculating because I don't know what Dr. Schaefer was thinking when he drew the simulation, but I would assume he was making the assumption that given that Dr. Murray prepared a 1-to-1 mixture in a 10 cc syringe, that would mean 5 cc's of propofol, it's 10 milligrams per ml, so that would be 50 milligrams of propofol along with 5 mLs of 1% lidocaine, which would be again 10 milligrams per ml, so 50 milligrams. So you'd end up with a 10 cc syringe containing 5 cc's of propofol, 5 cc's of lidocaine, 50 milligrams of each.
And Dr. Schaefer assumed that based upon toxicology reports, that there had been 5 milliliters of lidocaine given to Michael Jackson. Is that correct?
Also speculation on this witness's part. Dr. Schaefer testified to the scenario.
The objection is sustained. You may re-ask.
In Dr. Schaefer's report that he prepared in this case, did he say that the toxicology results at time of autopsy were consistent with 5 milliliters of lidocaine being given?
Yes, I believe he did.
And so that scenario basically comports with Dr. Schaefer's assumptions of 1-to-1, 5 milliliters of lidocaine, 10 cc syringe, but it's inconsistent with Dr. Murray's statement to the police, isn't it?
Well, it's inconsistent because Dr. Murray has repeatedly stated that he gave 25 milligrams, so he only gave 5 cc's from a syringe containing this 1-to-1 mixture.
So, along with Dr. Schaefer, do you reject this scenario?
I would reject it, yes.
Now, this third scenario involving 100 milligrams of propofol. I've got another exhibit I'd like to mark as QQQQ. 4 Qs. If we take that third scenario that he has rejected, and referring to diagram quadruple Q, that involves 100 milligrams in a bolus dose to Michael Jackson, correct?
Yes.
Now, that is inconsistent with Dr. Schaefer's assumption that 5 milligrams of lidocaine was given, isn't it?
Yes, that would assume that the entire 10 cc syringe contained propofol because it's 10 milligrams per milliliter. It's also inconsistent with the fact that Mr. Jackson always insisted on having what he referred to as anti-burn, which is the local anesthetic lidocaine, because propofol given in a 10 milligram injection like that through a small vein as he was receiving his intravenous would cause tremendous burning discomfort. And I think for that reason it is not logical.
So that the 100 milligrams of propofol with 5 milliliters of lidocaine would not fit into a 10 cc syringe, would it?
Absolutely not.
That's a double negative. Could we clarify it, please? Would?
Would it fit into a 10 cc syringe?
Absolutely not. You can get about 12 cc's maximal in a 10 cc syringe.
Now we've got 3 scenarios on the bottom of this diagram that involve multiple doses, multiple injections of propofol over various times. I'd like to go through these individually with you. Referring to what's previously been marked as defendant's triple I, that shows Dr. Murray giving 6 injections of 50 milligrams each.
That's what it suggests.
I doubt that 5 milligrams of lidocaine would have to be given with each of these, would it?
Well, presumably, if you're talking about a 1-to-1 ratio, yes. So that would result in a tremendous amount of lidocaine.
Would that involve filling a 10 cc syringe completely full 6 different times?
It would be quite a challenge to accomplish that in a 5 to 10 minute interval. He would be having to work extremely fast, and I doubt that he'd have time to accomplish that. I don't know how skilled he is in drawing up, but as suggested earlier, drawing propofol out of a glass ampule, as I'll show later, requires some effort, and I'm not sure I'd be able to accomplish that. It would be a challenge.
Now, we've never made that contention, have we?
No.
And it's not even a rational contention to be made, is it?
Well, it would mean putting Michael Jackson at deep sedation or even approaching unconsciousness, waiting till he barely wakes up, and then slamming him down again repeatedly. I don't understand the rationale for the simulation.
We've also got self-injections. These are 100 milligrams each. These are self-injections by Michael Jackson. Now, is this scenario that Dr. Schaefer came up with, would you describe this as just plain ludicrous?
Again, we've talked earlier about the difficulty in drawing up even 5 cc's. To have a patient who's somewhat sedated under the effects of drugs, drawing up at one time, it may be conceivable. Drawing it up 6 times over that period of time, 2 hours, is inconceivable, yes. He would be knocking himself out, waking up, figuring out how to draw it up again, and then whacking in another 10 cc dose, and he'd probably be asleep before he got all 10 cc's in. So in my world, this is not a very realistic possibility, or not realistic at all.
How about self-injecting 50 milligrams each?
That's only slightly less absurd.
I mean, would that include lidocaine also in that scenario?
Well, if you assume there was a 1-to-1 ratio, yes, it would include giving 300 milligrams of lidocaine, which is, again, a huge dose and could be just toxic of itself.
You would agree that that scenario is absurd also?
Slightly less absurd than the previous one, but yes.
I want to return to the first scenario. That scenario, Dr. He's 25. Now, that one's not quite as absurd, is it?
No, it's 25 milligrams, as we said earlier. That's a minimal sedation dose of propofol.
Now, I want to refer you to previously marked Exhibit Triple G to show Dr. Schaefer's full-scale drawing. Now, that depicts a 25 milligram bolus dose, doesn't it?
Yes, it does.
And that 25, well, it's a bolus dose. Why would a doctor, well, that doesn't depict a dose over 3 to 5 minutes, does it?
No, that depicts giving a presumably rapid bolus injection over typically 30 seconds or thereabouts.
Now, would Michael Jackson be capable of doing that kind of a dose?
Sustained.
Would a person who had an IV in place and was conscious be capable of injecting a bolus of 25 milligrams of propofol?
Speculation.
Overruled on those grounds. You may answer.
Yes, of course.
And in the event that the person did bolus dose 25 milligrams, that would immediately shoot propofol level up to the numbers that we have there on that diagram?
Well, Dr. Schaefer on this diagram shows it going up to about 5.5 or 6 micrograms per mil. It seems a little bit higher than I would have predicted, closer to 4.5 at peak. But again, it's dependent on how quickly the injection is completed. So if it's in 15 seconds, it's going to go perhaps to this level. If it's 30 or 60 seconds, it'll be more you'll have a little lower peak. So it's not unreasonable. I think it's reasonably depicts what I would expect to see in the plasma.
In this diagram, Dr. Schaefer shows it going up to 6.
Yes.
But in his, you recall reading his report that was written on this case where he said the 25 milligram dose would only go to 4?
Yes.
Which is correct? Do you agree with the 6 that he's got depicted here, or the 4 that he said in his report?
I think.
Well, it seems that that's the only choice. Sustained.
What would you say would be the accurate number that 4 milligrams or 25 milligrams would go to?
I think both could be accurate. It just depends on the speed with which it's injected. If you give it over 15 seconds, it could be 6. If you give it over 30 seconds, it could be 4. So it's all dependent on the speed at which you inject it.
Now, why is it written in the insert that it should be given over 3 to 5 minutes?
Well, the package insert for propofol, when used for max sedation, conscious sedation, suggests giving the initial dose of 0.5 milligrams per kilogram, which in Mr. Jackson would be 31 milligrams, over 3 to 5 minutes. to avoid any possibility of producing any acute respiratory depression or other profound effects like unconsciousness. It's just a safety mechanism to avoid initially pushing a patient into deep sedation or anesthesia.
Would it be accurate to state that if you inject it in slower, that it causes less shock to the system?
Well, I wouldn't use the word shock, but it has less cardiovascular effects, less effects on the heart, on the cardiovascular system, and the respiratory system. So if that's what you mean by shock, I guess yes is the correct answer.
Now, this diagram by Dr. Schaefer of the 25 milligrams bolus dosed in, that shows that it's spread out over a 10-minute period of time, isn't it?
Objection big as to what is being spread out over a 10-minute period of time.
Overall, do you understand it?
I must say I object as well because I don't understand
No,
it.
that's all right. You just answer the question.
Sorry.
Then the objection will be sustained. That's three of us.
This is majority rule, isn't it?
Your next question, Mr. Flanagan. Thank you.
The diagram depicted up there, GGG, that is a bolus dose of 25 milligrams, the blood levels and the brain levels stretched out over a 10-minute period of time, isn't it?
Correct.
On the other hand, if you had to condense it to fit into the 12-hour bottle that we've had on most of the diagrams, would the bolus dose, if it was given around 12 o'clock or just before, would it look like that?
Yes, I assume you're referring to this little hump here.
The one on the end.
Oh, I'm sorry. You're talking about giving it quickly.
Yes.
This is the 25 milligrams given over 3 to 5 minutes. This would be 25 milligrams given over 15 to 30 seconds.
And you referenced the 11 for the first hump and the 12 for the
Yes, sir.
other? Thank you.
What exhibit number is
Yeah.
This is
Exhibit?
exhibit.
Oh, is this a new one?
Yes. Yes.
Okay, we got to be clear. Quadruple Romeo.
Sorry, I saw it as the earlier one as well. So
That's natural.
It's very, very similar to the other one, but this one has it takes into consideration this 3 to 5 minute infusion at about 10:40, which is the small purple hump. And the other one that you described is the bolus dose in the vicinity of 12 o'clock.
yes.
Now, if we were to assume that the midazolam levels of less than near 0.01, the razapam level as it's depicted, as the depiction of Dr. Murray's statement to the police existed, of a O2, if that bolus dose was put in on top of those, would you expect adverse consequences?
Yes, I would.
What about if the bolus dose was put in on top of the femoral vein concentration that we know was present at time of death?
Well, I believe it potentially could have lethal consequences.
Now, why is that?
Because you're rapidly administering a bolus dose of propofol on top of a very high concentration of a benzodiazepine, lorazepam, and also additionally a small amount of midazolam. So you've got drugs that have additive or even synergistic effects, and I think the combination effect would be very profound.
Are you saying it's this combination right there that's potentially lethal?
Precisely.
They're being
I've drawn an X on exhibit RRRR. Now, you've got a lot of paraphernalia next to you on the stand over there. I'm wondering if you have a syringe?
I do.
You got a spike,
I do.
and you got an IV bag.
I do indeed.
I wonder if
I even got some bottles of propofol here that have been unopened, so if anybody wants to examine them.
I wonder if you could do us a demonstration of how you would fill up a syringe with, say, 5 milliliters of lidocaine and 5 milliliters of propofol.
Well, I don't have the lidocaine, so I just drew up some saline, but it has the same appearance. It looks a little whitish. But I drew up 5 because 5 of the lidocaine and 5 of the propofol, and you'll see the solution becomes much darker, or less transparent, I should say.
You could, Dr. White, hold it up a little higher. Are you comfortable in stepping down, or do you want to stay at the witness box?
Ma'am, has the saline already been put in the syringe?
Yeah, you want me to redraw that?
No, I just didn't know if it was.
Yeah, because I don't have any lidocaine.
No, if you just set it for what is in the syringe, I don't want to interfere with your demonstration. I just want to know.
I need an IV pole. Can I enlist the services of Mr. Flanagan? He's the tallest guy in the room.
Well, you want to hold it?
I'll hold it.
How about coming into the middle area on the side of Mrs.
get,
Theodoro,
can we
so
get-
the jurors can see?
Yeah, I would
Both
like-
of you could step back a little bit so the jurors and the alternates at the end, Mr. Flanagan, if you just be on an angle, because right now you're in the sight line of the jurors.
If we could have, I wanted to illustrate the way Dr. Murray would have given the propofol. The reason being is when Dr. Schaefer did his demonstration, he didn't use the correct IV infusion set. He used a set that had a very lengthy tube distal to the injection, the side port injection. And I think, as I recall, he suggested that all the drug would essentially remain, that Dr. Murray gave would essentially remain in the IV tubing. I just want to show you that that's not the case. If you can hold it up high.
And could both of you just move a little closer to the table for the sight lines?
And can I do it over here? Can I approach?
Well, let's just see. I want to make sure the jurors can view it. The jurors at the end, ladies and gentlemen, can you see?
Yes.
How about the other jurors on this end?
Yes.
All right? Thank you.
Okay. Have to turn it on.
Well, could you
If
demonstrate?
you could get a little further away from the jury box,
Okay,
please.
sorry. You don't want me to. They won't see it if I put it on the ground.
Well, now, you're in Mrs. Theodoro's airspace. You're over the DMZ here, Dr. White.
Okay, so this is exactly how a 10 cc syringe containing 50 milligrams of propofol and 50 milligrams of lidocaine would look. The white milky. Of course, as I said, it is saline.
How would you inject that over a 3 to 5 minute period of time? Would it go in?
Well, yes, and what I want to show is that if you give it slowly, you can see the tubing become discolored. Can you see that?
Well, if you ask me, I'll ask the jurors.
Oh, I'm sorry.
Can you see it? All right. Thank you. Yes.
And so you just would inject it, watching the clock, because 3 minutes seems like an eternity when you're injecting things.
Are you also observing the patient?
And you see it doesn't back up. There's no reason to turn off the IV. There's no reason nobody would inject with the IV not running, even though obviously this volume is less than a half cc. But you would just inject very slowly. I never inject over 3 to 5 minutes, I must say, because I'm impatient. But that's what the package inserts suggest, and that's what Dr. Murray said he did. So That's certainly a very safe way to do it. I think in a patient that's already had a lot of other sedative medications, diazepam, midazolam, and lorazepam, it's an appropriate approach to give it in a very slow manner. I'm trying to fill up the 3 to 5 minutes.
Could you very...
Are you getting tired? I thought you were an athlete. Okay.
That's all right. Let's just testify and ask questions, please.
Okay, the 5 cc's has now been injected. Okay? And again, what I would like to demonstrate is that you still see the residual in the tubing. So that's, you would see propofol because it kind of sticks to plastic. And there was no evidence of it going beyond the side port where I injected. Okay, that's all I wanted to illustrate.
With this. Thank you. Just carefully
Yes,
approach.
pretty good.
Your Honor, there's the desk here.
Okay. Dr. White, if you could be kind enough to
Oh, I'm sorry.
remove what's there, I'd leave it up to you to do that.
Thanks, Jason.
Deputy Jones? Thank you.
Now,
The jurors are commenting there's something by the jury box, which is why I didn't want people to get
sorry.
near it anyway.
This is the cap
Juror number 9, thank you.
extension tube.
Yeah, we'll take a moment to clean up. Is that okay?
Yeah.
Very well. Okay,
Okay.
thank you.
I'd like to turn our attention to the infusion theory of Dr. Schaefer. And the next exhibit would be is it S?
OCR.
S, 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 S. Okay, do you recognize that diagram?
Yes, I do.
And you recognize that as being a diagram prepared by Dr. Schaefer?
Yes, sir.
Now, do you reject this as being a possibility of occurring on the night that Michael Jackson died?
Yes, I do.
First of all, it's inconsistent with Dr. Murray's statement, isn't it?
Yes.
Was there any evidence at the scene that this occurred?
objections for the period of silence.
The objection sustained to the form of the question. You can ask the witness to explain his opinion and the basis.
In your opinion, in the event that this were to occur, what would you expect there to be at the scene?
Well, first and foremost, you'd need some mechanism for dripping the drug into the patient. So you'd need an IV delivery system. You would need some mechanism for holding this large bottle of propofol. And the fact of the matter is this handle was on the bottle that was obtained at the crime scene had not been activated until Mr. Walgren did it in the courtroom. So it was never used. And so the only way that's been hypothesized to hang this so you could give a delivery of the drug is to cut a bag and somehow put it in the bag. There's no way to secure it there. And I would imagine that if Mr. Jackson was sleeping in his bed with an IV in his leg and he rolled over or moved his leg, that this thing could easily just come right out of the bag. So I don't know how you could maintain it unless it was perfectly still. The other problems with the theory are it would burn.
That propofol bottle.
I'm sorry?
That propofol bottle you have, do propofol bottles come with a suspension strap?
Yeah, you can see. I think this one's more apparent. This also has the same strap, which... You want me to demonstrate how you hang it?
No, just a minute. I want you to... We're going to show you a photograph. I'd like to show a photograph. I don't have a hard copy of it here, but I will give the court one, of a propofol bottle. This is
you're displaying a photo, and you represent that you'll have the hard copy of this photo.
Yes, I will.
Do you want it marked?
Yes. I would like to have this marked as exhibit, I believe it would be T.
Quadruple tangle.
Quadruple tangle. Now, that is the 100 milliliter propofol bottle that was found at the scene in an investigation on June 29th of 2009. What is there about that propofol bottle that would indicate to you that it had not been suspended?
Well, it's, I think, fairly obvious. There's a little tab you can see above.
You got a laser?
Yeah, I do. Sorry. Above my laser. Right at this point it says lift here. And this is analogous to this little tab on the smaller bottle. This is a different manufacturer. This is APP Pharma, and that's Hospira. So there's some differences, but it's the same hanging mechanism. Also is shown on this 100 milliliter bottle. You can see it right here.
That bottle has previously been identified as People's Exhibit 3.
And it's sealed in an envelope.
It's sealed.
You're opening up the sealed envelope?
Yes.
Thank you.
And this, and is this a propofol bottle that is depicted in that picture?
Yes.
Now, when that propofol was collected and seen, it's been stipulated that lift tag.
Let's keep that apart from
Yeah,
the
sorry.
other bottle.
Yeah.
Maybe you could move those other items
Okay.
down or to the side, Dr. White. Thank you.
Okay, sorry.
It's all right. How about the syringe as
Yeah.
well? And the cup, if you could move it to the other
That's
corner.
my
That's great.
disposal.
Thank you.
As that propofol bottle is depicted in this photograph, it's obvious that the lift has not been deployed, isn't it?
Correct.
And it's been stipulated that that lift was unused and not deployed when it was collected at the scene.
Correct.
And the fact is that lift was not deployed until it was deployed by Mr. Walgren in this courtroom during Dr. Schaefer's demonstration. Is that correct?
Yes, it is.
Now, would that indicate that that bottle was not hung at the scene?
Certainly would indicate to me, as a clinician.
Now, if you were going to use the double IV line infusion technique, what's the method that medical professionals use to hang a propofol bottle?
Well, this double technique is what we used years ago when I did my very first study because we didn't have infusion pumps. Now they frequently run undiluted propofol through an infusion pump, but in the early days before we had the electronic pumps, we just made up dilute solutions and in a parallel system, one containing propofol and then a background infusion which would just be saline, as shown in this example. You're then dependent on gravity. For the drug to be dripping in, it has to be at a higher level than the background infusion or the saline infusion. And I think Dr. Schaefer illustrated that very nicely when he tried to get the drug infusion to run, and it really didn't run until he turned off essentially the background infusion, and then the drug solution ran, I think, very quickly. I kind of recall that demonstration.
So it's the best, you want the propofol bottle deployed as high as possible on the IV stand?
Yeah, you need some distance so that gravity can have an effect. Otherwise, if they're at essentially the same level, which in fact they were when he had stuffed up in this empty saline bag, it barely runs, and you essentially have to turn off the other infusion and run it as a straight, undiluted solution, which is actually a dangerous practice and not one that I think clinicians should use.
So is that the reason why the manufacturer of the propofol bottle, or the propofol, puts a suspension device right on the bottle?
I think it's to make it convenient for infusing when you want to give the undiluted drug, yes.
Now, can you think of any advantage to not using the deployment, the hanging strap? Can you think of one single advantage